Good evening, everyone. Thank you for joining us tonight to mark World Diabetes Day 2025 here at UCL with our panel event this evening, Transforming Diabetes Care, UCL Research Innovations and Discoveries. My name is Hanna Baldursdottir, and I am a recent graduate on the MSc in Dietetics here at UCL, and I'm also a current student representative for the BDA Women's Health and Fertility Special Group. I will be your chair for tonight's event. So during this panel, our UCL experts will talk about some of the transformational work taking place in their respective fields and how new and different approaches to diabetes will change the future of diabetes care and management. We encourage active participation, so please feel free to go to slido.com to submit your questions for our panelists using the event code #UCLDiabetes. The Slido details will be shared on a slide in Zoom webinar by our video producer as well. This panel event will be recorded, and a link to the recording will be available on our website following today's event. So without further ado, I am now pleased to introduce our panelists. So first we have Dr. Adrian Brown, who is a National Institute for Health and Care Research Advanced Fellow, as well as an Associate Professor in Nutrition and Dietetics at UCL, specializing in obesity, diabetes, bariatric surgery, and weight stigma. Next, we have Professor Lucy Walker, who is a professor of immune regulation at UCL, researching immune regulation and T-cell control to prevent autoimmune diseases like type 1 diabetes. Then we have Professor Anastasia Kalea, a professor and academic program lead for the MSc in Obesity and Clinical Nutrition at UCL with expertise in obesity, cardiovascular disease, and international nutrition education. And finally, Dr. Ken Lee, who is an associate professor of AI and healthcare at UCL, focusing on AI-driven diabetes management, clinical risk prediction, and healthcare innovation. So thank you all for joining us today. We will now hand over to our panelists for their opening remarks so you can find out a bit more about their respective fields. Following the opening remarks, we'll have a discussion amongst the panelists before moving on to the Q&A with you all. All right, so in order to kick off these open remarks, I would like to ask our panelists to respond to the following questions. Can you tell us about your research specialism and what developments you have seen that are changing the way that we approach diabetes? So I'll start with you, Adrian.
Thank you very much, Hannah, and also thank you to yourself for putting up this fantastic event. So how did I describe my research? So I work in the Centre for Obesity Research, as you said. So our research really focusing on all things obesity.
Right.
But in addition to that, by trade, I'm a senior specialist weight management and bariatric dietitian. So I worked in the NHS for many years. I've got about 20 years of clinical experience, really helping patients living with obesity, but also a large majority of them were also living with type 2 diabetes. My PhD really focused on the advanced stages of type 2 diabetes, really on individuals on insulin. And we did a clinical trial looking at these patients and using low energy formula based diets, total diet replacements, to help to reduce down insulin doses and also weight. And we got some fantastic results in this population that's often forgotten. We often think about patients with prevention and also now type 2 diabetes remission as well. And there's national programs, but we've got a patient population that often is forgotten. And I think that's really important. I think, as you mentioned just before, a lot of my recent work is really focused on weight stigma. But it's understanding that people living with diabetes also experience stigma. So this idea of stigma are really those stereotypes, those prejudices, that blame related to patients living with diabetes. And there's a lot of connection we see with weight stigma as well. So when we look at type 2 diabetes specifically, around 80 to 85% of people living with type 2 diabetes are also living concurrently, also either with obesity or overweight. And so there's a lot of connection. And what we know about stigma, both for obesity and diabetes, is that it impacts both psychological and physical health. And so what we see, and from research that we've done as well, is that patients have a tendency that if they feel stigmatized in healthcare environments, and this is where one of the major places for weight stigma is that people actually avoid healthcare. They actually don't go back. It impacts on their glycemic control as well, and their adherence to actually programs. And often some of that stigma can really come down to the types of language that we use when we actually see patients. So a lot of work that we've done has really been looking at weight-related terms that patients would prefer to be used by healthcare professionals.
Yes.
And so what we found from that research was really that neutral terms, things like weight and healthy weight or BMI, are preferred terms as opposed to stigmatizing terms like quote unquote obese. That's often a term that's used. And these terms really reflect on the idea where there's a lot of blame in terms of personal responsibility. Type 2 diabetes is seen as a lifestyle condition. It's seen that actually if you just fixed your lifestyle, if you just did something different, did more exercise or ate differently, you wouldn't have developed type 2 diabetes or obesity. And that's not the case because both conditions are really complex with genetic factors that we'll be talking about in a minute. There's social factors, there's psychological factors. And I think we've got to appreciate about the complexity of this. So a lot of my research is really trying to look at that connection between stigmas, but also trying to help in terms of things like training. And I've done work with Professor Kalea related to stigma and training, and really trying to move forward to make sure that patients feel safe when they go and see their healthcare professional, because ultimately weight stigma and reducing stigma is really about equity of care. And everybody deserves equitable care. Doesn't matter who you are, you deserve to be treated with respect and dignity when you see anybody in the healthcare system. And I think that's really where I've been seeing some real drivers forward. So things like language matters, that's from the NHS England related to diabetes, has really helped to move that forward. But also we've seen work from Obesity UK related to language matters as well, and we've done that work. But you said before about what has changed and what I've seen as a dietitian changing. And I think there has been some fantastic research that's come out from around the world that has really pushed forward this idea of remission, type 2 diabetes remission. And before, all we did as clinicians was manage glycemia. People would come in, we'd manage their blood glucose, improve their dietary quality, try to get them to lose a bit of weight, but then that was it. But really, we've seen a step change in terms of remission now being as a key element of now clinical care. So from a dietetic point of view, and because we've got dietary elements to help people get remission, I've really found that absolutely fantastic.
Well, that's great. And thank you so much for that. I know that, that sounds incredibly empowering. And I definitely learned a lot in my time here in terms of patient-centered language. And that definitely transformed my practice. So thank you for that. Over to Lucy, the same question.
Thank you. So I work on type 1 diabetes. And this is the form where the immune system destroys the insulin-producing cells in the pancreas. So we rely on our immune system to defend against infection with bacteria and viruses and so on, but sometimes it mistakenly attacks our own tissues, and then you get an autoimmune condition like type 1 diabetes if the pancreas is attacked, rheumatoid arthritis if the joints are attacked, and so on. So my lab is very focused on trying to understand exactly which immune cells and which molecules, which pathways are involved in causing type 1 diabetes. What is that dangerous immune response that targets the insulin-producing cells, with the idea that if we can understand the steps that lead up to this destruction, we can then come up with new ways to intervene and to actually stop that autoimmune response. And these sorts of therapies that target the immune system are called immunotherapies. These are therapies that we've seen a lot of in cancer, actually. So immunotherapy is now widely used in lots of different cancers. And in that setting, what we're trying to do is boost the immune system. So we get better immune responses against the tumour, we get rid of the tumour. And in autoimmune conditions, we actually want to be doing the opposite. We want to be tuning down that immune response and curbing that destructive immunity. So I think immunotherapy is something that we're going to be hearing a lot more about. It's sort of the next frontier, I would say, in how type 1 diabetes is treated, because since the discovery of insulin, we've not really fundamentally changed the way we treat type 1.
Right.
So before insulin was discovered, a diagnosis of type 1 diabetes was basically a death sentence. So, the life expectancy would be around 4 years. Many people died within months. So the discovery of insulin was huge. That profoundly changed treatment for type 1. But then since then, for the last 100 years or so, we've certainly had better insulins, better ways of using them. So there've been a lot of refinements which have made a big difference. But fundamentally, what we've been doing is the same. The immune system destroys the capacity to make insulin, so we have to put back insulin by injection. What we've not been doing is actually trying to tackle the root cause, tackle that immune response that's causing the problem. And this is what immunotherapy is all about. And we now have the very first immunotherapy has received FDA approval.
Wow.
And so we're really starting to see this change coming in. And that's a therapy that can delay the progression of diabetes by around 3 years, and it's not available yet in the UK. But this is definitely the direction of travel. So the challenge now is to come up with better immunotherapies that will have a more profound impact, and then develop these and test these. And this is what my group is now fully focused on.
Wow. Well, that sounds like a really exciting time and something to kind of keep our eyes out for. And I know that your lab here is certainly kind of paving the way. So yeah, really excited to hear more about what you have to say about that. And now I'll pass it over to Natasha.
Thank you, Hanna. So my research interest has been for the last couple of decades on diabetes complications. And it started looking into genetic variation, initially for type 1 diabetes, and how that affects not only type 1 diabetes risk, but also the progression of disease. So how aggressive that disease becomes. And my interest was also to understand the role of nutrition in this disease progression. So try to tease out this gene and environment interaction and to see the components of this dietary pattern on the dietary habits that would affect how aggressive the complications will be. Looking at large vessels, looking at smaller vessels, we know that vascular complications are part of that of these comorbidities that come along and the complications that come with diabetes. And I wanted to understand the role of nutrition, not only in managing glucose monitoring or glucose balance, but also in understanding how nutrition would affect the immune system or the kidney function or different aspects of that disease phenotype. Later on, the last few years, my particular interest was moving a bit beyond that molecular nutrition aspect of that and understanding bioactive compounds and nutrients, but also seeing how we can educate healthcare professionals that treat patients, not only in appreciating the evidence and seeing the role of nutrition in the care pathway, but also in doing it in a way that will be effective. So I see my role at UCL in the programs that we have created on trying to enhance communication skills. for healthcare professionals, using the right language, as Adrian mentioned. Try to create a map of how do we transform the way we educate doctors, dietitians, anybody in the healthcare profession to build that relationship with the patient, but also to receive that feedback from the patients as well. And at the level of policy, to try to understand how we design dietary guidelines that meet the needs of the patient when we talk about diabetes. How do we communicate messages in the community, in schools, in university students, and do that in an effective way that respects the patients? And at a very different level, how do we engage the patients to tell us what they need?
Right.
And how can this transform the way we conduct research, but also how does this affect the way we educate healthcare professionals?
Right. Well, we've definitely had some great educational and done a lot of role playing and how to establish rapport and trust with patients. And I think that as UCL students, we're definitely going to be going out into the world, hopefully being better clinicians because of things exactly like that. And now finally, I'll pass it over to Ken.
Hi, thank you. Thank you for the opportunity inviting me here. So my research is to tackle diabetes using a very different way by using the modern technology, especially artificial intelligence and machine learning. So my daily job is to, explain what is machine learning to clinicians and explain what is the diabetes to computer scientists. But sometimes neither group thinks that I'm doing a good job. Yeah, so, we are living in a modern digital world now, and we are creating a lot of data every day by smartphones, smartwatches, and all the electronic health records now in the hospital are stored in an electronic form. So all of these are certain types of data, but actually most of these data are underutilized clinically. So in the hospital, so doctors normally use HbA1c or some BMI. There's those basic values to make decisions, clinical decisions. So this is where AI can help us. So AI can transform this rich data to actionable insights to help people manage their diabetes and the glucose levels. For example, many people, especially people who have type 1 diabetes, are wearing CGM, continuous glucose monitors. And AI can help us using the current and the previous level of glucose level to predict the future glucose level in the next 30 minutes or 1 hour. So that can prevent hypoglycemia or hyperglycemia by taking some actions before that in advance. And another work we do is to design personalized insulin advisor. So now most of people using an equation. So this is what is my current glucose level. This is the carbohydrate, fat, or what I input now. And so this is the units of insulin. I calculate that I need to inject. But this is a standard format. So, but if we consider your personal data, your genomic data, and other personal data, so it can optimize or personalized this calculation to make these units specifically designed for you. And also, AI can help us bridging the gap of inequality of people. So sometimes people cannot afford a CGM or cannot afford a very expensive medical devices. Can we use other physiological values or data to help us manage our glucose level? So this is we can. I'm doing research, try to find the correlation of other physiological data and glucose level. And another perspective I'm working on is the large language model. So, people now use a lot of large language model in their daily life. So large language model is a very good tool to do some education, explainability, but how good it is, there any risks associated with that? And so all of these are unknown questions that I'm working on.
Okay, that's really, it's always so fascinating to see how technology drives things like this forward. And yeah, I think a lot of us know about CGMs and things like that, but not so many of us are really aware how they can be used for, like you said, predictions and optimization. So really, really interesting stuff, everyone. And thank you all for your fantastic opening remarks. So we're going to get down to some more questions as well. I have a few questions that are, kind of directed towards each of you. Before we move on to the audience Q&A, I'm going to ask these questions to our panelists. And the first question is, what role does collaboration, so for example, between individuals, disciplines, or institutions, play in accelerating innovation and discovery in the field of diabetes research? So this question is for all panelists. Should I call on someone, or is anyone?
I'm happy to.
Great. Let's go with Lucy then.
So in our research, collaboration is hugely important. The immune response is really, really complicated. There are lots of different cell types, and they're all talking to each other, and they're all moving around and interacting. And we can't be expert in all of these different cell types. So what tends to happen is different groups have their own area of expertise, and then we collaborate with each other to share insights and to share research tools. And this tends to work really well. We're kind of constantly reaching out internationally and just sort of asking people about their research, whether there's something that we can utilize from what they've been doing. I think the other important aspect for us is we do a lot of interdisciplinary collaboration. So we have collaborations with chemists, with mathematicians, with physicists, clinicians, of course. And again, it's really important to us to be able to bring in lots of different types of expertise to fit whatever particular project we're working on. The institute that I'm based in, the Institute of Immunity and Transplantation, we actually have a special partnership with Osaka University in Japan, which is where Professor Shimon Sakaguchi, who just won the Nobel Prize in Medicine a few weeks ago, is based. And that Nobel Prize was for the discovery of a particular immune cell called a regulatory T cell. So these are white blood cells that are specialized at regulating immune responses, so suppressing unwanted immune responses like autoimmune responses. And actually one of the immunotherapies that we're trying to develop is aimed at exactly boosting that population of regulatory T cells.
Everything's
at the same
aligning.
Time. Exactly, yeah, exactly. So actually that international collaboration has been really, really important for us in developing that immunotherapy approach.
Wow, amazing. All right. Well, I can pass this over to Adrian, maybe.
Actually, you were talking about opportunity to talk about collaboration. Actually, quite interestingly enough, we just turned up and me and Ken are now going to be collaborating, and that's what I love about the environment at UCL.
Yeah.
There is such a broad range of expertise here that allows you to find someone that does something that you're looking for.
Right.
So in this case, I'm going to be speaking with Ken about AI. And now I'm really intrigued about type 1 diabetes and what I can do here. So we can talk, yeah. And myself and Natasha collaborate already on several things. And so collaboration, I think we'll all agree, is absolutely key to driving forward research. And we've all got examples of that. I think a key part of collaboration is also collaborating with our wider organisations that link in with diabetes. So groups like Diabetes UK, like the American Diabetes Association, like the European Association for the Study of Diabetes, are absolutely key to getting our research out there. So involving them and getting collaborations with them to drive forward those important topics and sharing is absolutely key for me. And so I'm chair of the Specialist Obesity Group for the BDA. So from a dietetic point of view, we collaborate hugely with the diabetes group because there's huge interconnectability, and particularly with the new incretin-based therapies that are now coming out. It's on the lips of everybody, particularly around diabetes, particularly about management. And so those collaborations are incredibly important to drive them forward, but also sharing the science with both the community but also the professionals that lead with it.
Right. Okay.
Shall I?
Yeah. Go ahead.
I think multidisciplinary collaborations give us the opportunity of a different perspective in the same problem. And this is very useful because you overcome barriers a lot easier. And you see different ways of resolving a problem. We talk, for instance, in the class you came across probably, Hanna, architects coming to talk about obesity and the design of our cities. We talk with people that treat patients with rheumatoid arthritis about cardiometabolic guidelines. But we talk about designing of our schools, school catering systems, very different when we take behavioral scientists into discussion. And that makes not only our practice, but also our research a lot more effective. But something that I wanted to highlight is it's not just the partnership between different disciplines and organizations. It's partnering with patients that is extremely useful to prioritize properly our research aims and what we're supposed to emphasize our teaching on. With the support of funding agencies now, we have the patients involved in research protocols design. We have the patients involved on the way we look at the data or present our study results. And this is extremely useful. And I know that all of you will agree that this has changed the way we communicate our science the last few years. And I find that extremely useful and necessary. Going forward. Yeah.
And Ken?
Yeah, I would say collaboration is the key in AI research as well. And I would take two examples. So for example, one is that several years ago, we conducted a clinical trial and we have a focus group and we want to design an app to record people's food intake and try to associate with them the glucose changes. And in the focus group, the patient give us a lot of good feedback and help us to improve the protocol, to improve the user interface design a lot. One thing I remember is that one patient suggests that, okay, because every time they need to, record the food intake and how many grams of carbohydrate, how many grams of fat, that's very complicated. So why not just take a photo and, input all of them and save it. So every time I had the same food, fish and chip, just click it or, just one click, solve all the things. So I think, whoa, that's a great idea. And so we incorporate that function in our app interface, and that's a very successful function, I would say. And another example is that because we are considering, design an app for AI algorithm for all the people around the world, people living in London and people living in Tokyo, they're very different. And they have very different breakfast, lunch, and dinner. So the facts are very different. So only if we have all the data and we can find a way to process the data in a private preserving way. So that's how we can, build an AI model that can fit or suitable for everyone. So that's the key for the AI research in diabetes as well.
Right. Wow. Some great examples of how collaboration works not only for researchers and research, but for the people who will be benefiting from said research. All right. So for my next question, what practical steps can we take to ensure individuals living with diabetes feel empowered and supported across different environments, such as schools, workplaces, universities, and beyond? So this question, I'll direct it, Adrian.
Yeah, so I'm going to follow on what Anastasia and Ken just said about the importance of the patient. And I think patients need to feel empowered to be able to manage their own condition. I think that's so important. Right. If we look at the healthcare professionals and the involvement that they actually have in care, it's a fraction of the time that the people are actually managing their condition. I mean, if we start to think about a dietetic involvement, it might be once a year, it might be twice a year, but that's for half an hour. So you might get an hour of a dietitian's time in a whole year. So how can we help to empower and give autonomy to the patient in terms of being able to manage their own condition? I think that's incredibly important. But also what we need to be doing is we need to be hearing the patient's voice, and this really comes on to that. And we need clinicians and also our clinical services to involve the patients about what do they need to help empower them to be able to manage that. So that's really about getting people and getting patients involved in terms of that patient voice to ensure that we really, as clinicians, as researchers, make sure that the patient's at the center and we are doing the things that are going to help them. And in some research that we're doing at the present time, it's really interesting. We're developing an intervention to help people to lose weight. And we spoke to clinicians about what they thought we should do. And so I had that before going in. And then I went and spoke to the patients and they said something completely different. And I was just like, wow. So I think sometimes we think we know what people want, but it's not until we actually ask them and say, hey, what do you want? And then they go, we want this. And that hasn't worked. And we go, oh, you're right. and so we need to be listening, ultimately. That's one of the key steps, particularly for empowerment for me.
Right, okay.
Listening, but I often say listening to understand, right?
Yeah.
Not listening to respond.
Yeah.
So trying to understand what the patient is actually saying, try to decode the message. And in order to do this properly, try to make them feel comfortable to share what they have to share. And usually the patient is contributing to the diagnosis and the path they would like to follow. I love the term autonomy that Adrian used. And you mentioned if empowerment, I completely agree, is key in that. Feeling that they can take control of their chronic disease and they can manage it effectively. What do we do in a university setting? We're trying to build communication paths to allow this listening to be more effective, to allow our students to tell us what they need. To allow the students to ask for a variety of special arrangements that we have in place for their learning journey to be better. At a work environment, the same rules apply. To make this a friendly environment for people to go about their lives so that they feel supported, but they feel that they will not be discriminated because of a chronic disease they're managing. And I think, in the cornerstone of that is be aware of the unconscious biases that may exist there and try to facilitate honest discussions and better communication.
Okay.
I think following on from that, I think very much so, you mentioned unconscious bias, but how do we help people? Because there's two types of biases here. We've got our conscious bias. We know we have bias and we act differently, but there's this unconscious bias, this bias that unfortunately everybody has, and they behave differently towards certain people. not consciously, they just behave differently. And we see this in healthcare. And so an important aspect of this is really about training. And myself and Anastasia published a paper, a scoping review a few years ago now, that really focused on how do we help clinicians to understand and reduce down stigma. And I think that that's an incredibly important part of empowerment, but also appreciating that we should try to reduce the blame that people will be come into our clinics, because people will be coming in with what we call internalized stigma. So taking those stereotypes that they think around society, and I'll use obesity, for example, where people believe that people might be lazy, they're not adhering, and they will believe that about themselves. I can't name the amount of patients that have come in and said, why are you struggling? Go, oh, because I'm lazy. And this will be a person who's got a full-time job, has a family at home, and does other activities. And you're like, well, that's not easy. And so this then precipitates down into these ideas. So if we can help to empower people to understand, actually, diabetes and the development isn't necessarily a personal responsibility. It's not your fault. And going down to the sort of the gene element and I think that's so important related to that. And so building in that training is important.
Right. I mean, the internalized stigma is definitely something that is really hard to work through but as you said, just empowering patients. Can I ask a short follow-up question? Because you said something about how a lot of patients may only see you twice a year, and that in order to kind of give them the tools, it's very important to be able to give them tools when they're not going to be able to see you for quite a long time. What are some of those?
I think that's a really important question, and something that I think there's been a lot of education, particularly education material. We do a lot of work around behaviour change to help individuals. One thing that I think has really changed related to support is technology. And when we're coming back to type 1 diabetes, and we've seen a huge change in technology to help people to self-manage. So it started off with CGMs, it then started to insulin pumps. Now we've got automated insulin delivery systems where the CGM talks to the pump, and that sort of idea to help people to guide. And so Ken, I know you're the person for tech, so what have you sort of found for empowering patients?
Yeah, I agree that technology changed the landscape a lot, and for some people it's life-changing. And I also want to echo your point that we should focus on the patient center or clinical center research. So nowadays technology is developing very fast. We want technology to help people living an easier life and less expensive, but not add burden to patients or clinicians. So when we develop technology, that's very important. We don't want patients or clinicians to spend more time on medical devices, but less time. Make the life easier, but not more complicated.
Yeah, very much so. And I think this is where potentially digital health might be able to come in as well. And I think we've traditionally had a model as healthcare professionals where we have to see the patient. We believe, okay, I've got to see them face to face. But actually, with increased numbers of patients with diabetes, what we need to be doing is we need to see laterally. What can we provide for that continued uptake? The digital health, in my belief, actually potentially has the opportunity to have, not replacing people face to face, but as an add-on. And this is where technology, I think, is going to be a key element.
Adaptability.
Yes, indeed.
All right. Well, thank you so much for providing plenty of food for thought. And so now as we look into the future, what advancements, priorities, or considerations do you think will transform diabetes management over the next decade? I'm going to direct this towards Ken first.
Yeah, and we are doing a lot of research now, and one is multimodality research. So we collect different data, different modality like images, like electronic health records, like genomic data, like behavior data from smartphone and large data set. So how we can use all of this data to make your decision making or medicine like more precise. So not just try one, it doesn't work, and try another one, right? That save time, save money. That's very important. And another one is that recently the smart agent is very popular. So basically, maybe in the future, you will have your own personal agent, or like as a manager to manage your diet, lifestyle, glucose level daily. And your agent can talk to each other, learn from each other, and improve your glucose levels. That's possible in the future, I would say. Yeah, and a lot of development in large language model, and now more and more specific trend large language model for healthcare have been developed, and how they perform and how to avoid hallucinations and make it more reliable. That's something we are currently doing.
Right. Lucy, do you have anything to add to that?
Yeah, so I already talked about immunotherapies and how, that's going to be a huge change in the way we treat type 1 diabetes. But the other thing I wanted to mention is that another development where we've really seen a lot of progress is catching type 1 diabetes very, very early before the symptoms actually appear. Because when you start to have this immune response against the pancreas, there are molecules that appear in the blood, autoantibodies, they're called, and they are a trigger. They are a sign that this immune response has initiated. And we're able to actually screen people, pick up these autoantibodies, and then know that somebody is going to, is at the early stages of type 1 diabetes. And I think that ability is going to transform the way we treat type 1.
Right.
Because essentially, one of the problems at the moment is sometimes a diagnosis might be missed. Somebody may be diagnosed very late, and actually about a quarter of children have this sort of very traumatic diagnosis of type 1 diabetes where they have DKA, diabetic ketoacidosis, which is really severe. It can be life-threatening, and it's just very traumatic for, the whole family. If you knew that you were in the early stages of type 1 and you knew what symptoms to look out for, you avoid that threat of DKA. So you kind of, there's a big win to be had there. But I think the other big advantage is as these new immunotherapies come online, we will be able to deploy them much earlier before there's been as much destruction in the pancreas and loss of insulin-producing cells. So actually, we expect that outcomes will be better if we can get in there early. So I think, from my perspective, looking to the future, one of the key things is going to be actually getting these screening programs rolled out. We know, for example, that 95% of children who develop diabetes in puberty will already have these markers in their blood, these autoantibodies, by the age of 5. So you can envisage if you have some sort of screening program where you can actually pick this up early, you can have this enormous benefit on reducing DKA and this sort of traumatic diagnosis, but also in the long term, deploy these immunotherapies much earlier on and hopefully delay symptomatic type 1 for, as long as we can.
Wow, very interesting. And then that screening that you mentioned, would there be certain criteria, or would it be kind of, what would you look for? What would you screen?
At the moment, this screening is only done in a research setting. So there are a couple of screening programs in the UK, one aimed at children, one aimed at adults. Because although the peak age of diagnosis is sort of, 13, 14, actually you can get type 1 at any age, and over half of the type 1 diabetes diagnoses are in adults. So there are these screening programs that are sort of understanding how to deploy these sorts of programs, flushing out what the issues might be, how to do it. essentially, it's quite easy to do. You can do a blood spot test and send that off to the lab. If you need a blood draw, you can then come in and be tested. And these sort of systems are now being developed with a view, ultimately, I think, to having a national screening program. I think that would be fantastic, and that's where I think the direction of travel should go.
Yeah, that would be really great to see. Yeah, and Natasha.
Early diagnosis, absolutely. The technology, absolutely, but also using the information we have about the importance of nutrition in delaying the progression of the complications is part of the things that we can do better and we can improve upon. And of course, we will need a new event to talk about all of the different aspects of that. Not only providing appropriate advice, focusing on habits and behavioral approaches, because the patients are managing a chronic disease. It's not going to be something that they will have to deal for a few months and that's it. So lots of these aspects, but also when we talk about a chronic condition, improve the environment. And that's where public health nutrition comes in the discussion. The environment, the food environment that people are shopping and buying and moving and going about their lives, and making this welcome to them to have healthy, to go and have healthy choices. And if we want to make it a bit more challenging to look at the impact of our diet on these choices and how does this affect the role that we play on climate change, and plant-based diets have a place in managing complications for diabetes, and try to look at how do we shape this food environment to be welcoming.
And so can we get kind of that theme of adapting and just kind of using technology, using what we have at our fingertips in order to just press on, I guess. It's really, really interesting to hear all of your perspectives. Of course, I've had the pleasure to hear from Adrian and Natasha in class, but getting more perspectives on things like AI and immunology are really, driving even my own thoughts and the conversations I hope to be having. So thank you so much for all of your answers. We will now move on to the Q&A with the audience. So please do submit any questions that you may have by going to slido.com and using the event code #UCLdiabetes. The Slido details will also be shared on a slide in Zoom in this webinar. So by our video producer, you can look out for it there. All right, so let me take a look now.
I'm going to grab some water.
All right. Shall I just read from the top? Okay, great.
There we go.
Yeah.
Surprise.
Right. Okay, so our first question is, some demographics tend to be at more risk of diabetes. So, for example, South Asian people, Black British people. Is this linked to famine history, changing gene pool, or diet due to cultural and socioeconomic factors? How can they be given more tailored care?
Okay, I can start and fit in. I would say that there's not one thing that would make them. It's usually a combination of different factors that seem to make the risk different. So very often, I mentioned earlier, my work was on has been on one of the genes that contribute to type 1 diabetes, so the receptor for advanced glycation end products, and we know that genetic polymorphisms in this receptor make this disease progression and the risk very different for specific subgroups of people. We know from other work on obesity field that people with a South Asian genetic background, they have higher adiposity and lower BMI levels. And we know that there is a link between a percentage of adiposity and risk for type 2 diabetes as well. The environmental conditions, absolutely, the way people eat, the amount of saturated fat and simple sugars and low fiber in their diets, just the few of the risk factors that have been studied in type 2 diabetes. And lifestyle is not just the way we eat, it's the way we move around our lives, it's the physical activity patterns and all of that. Very often, a hidden layer that we're not very good at picking up is how good we are in early detection and diagnosis. So that affects when do we exactly capture the disease and how aggressive that becomes very quickly.
And I think you mentioned that, I agree with Natasha. I guess you also mentioned about what do we do?
Yes.
And I think it's about engaging with the actual communities, going out to the communities and actually engaging with them.
Right.
And in terms of understanding around diabetes, about what it is, I think there's a variation across our society in terms of understanding. So I think we need to be speaking to the patients and getting them involved. Again, you're gonna hear me like a broken record here, but about that. But I think that element, and there has been some fantastic work that's been done about, again, going out to those communities and speaking to them and focusing on the things you were speaking about, Natasha, and then developing treatments to try and support them.
Right.
Explain to them the early signs and symptoms.
Yeah.
When do they need to speak to a healthcare professional? And
Good. Because I think at times when we look at the literature, sometimes people out that have a condition are actually a little bit fearful of coming to speak to healthcare professionals. They're a little bit worried.
True. Yeah.
And so how do we engage with people that might not come? It's not about the people that come and see us, I think. It's about the people that aren't coming to see us.
Right.
Yeah, it's the people that are not trusting of what we say. And so I guess it's about how we increase that trust element as well, isn't it?
Yeah. Which is a lot of what we've been talking about, building the rapport. And yeah. All right. I'll go on to the next question. Does diabetes affect hearing as well as eyesight?
We know it. That one of the complications,
the earliest complications, is diabetic retinopathy.
Right.
I'm not sure about hearing, but I know that diabetic retinopathy very often it's picked up before parents are aware of type 1 diabetes in their children, and that's the first thing that brings them to an ophthalmologist. And that has to do with microvascular complications in the eye. There's a variety of available treatments depending on the stage, of course, but I don't know that much about hearing, I have to admit.
No, definitely the nerves and the kidneys.
I will look it up though,
But we'll look it up.
All right. Okay, so next question. I've heard about stem cells being used to help treat type 1 diabetes. Do you think this will have become a widespread and common way to treat type 1 diabetes soon? Yes.
So, yes, I can speak to this one. So, one of the ways that you could potentially get around the fact that your insulin-producing cells have been destroyed is to transplant new insulin-producing cells. And in fact, we know how to do that. You know, that can be done. But there are a couple of problems with that currently. One is that the immune response that destroyed the first lot of insulin-producing cells is still there and is just going to destroy the ones that are transplanted. And we're working on trying to overcome that issue. But then the second issue is that you need a deceased donor to actually give you these insulin-producing cells. So there's been a lot of work over a number of years around trying to generate insulin-producing cells, so beta cells or pancreatic islets or islet organoids, sort of artificial versions of these cells from stem cells. And this has been ongoing for a long, long time. I think it's proved much, much harder than people initially thought it was going to be. But, progress is now really ramping up. And people are also learning how to actually play with these sort of model beta cells in order to try and evade the immune response a little bit. So express certain molecules in them or knock out certain molecules from them.
Wow.
So this is an area that I think, we're seeing a lot of progress in, and I think it will start to become more mainstream.
Right.
Not immediately, but it's coming along for sure.
Okay. Wow. Yeah, I actually have never given it much thought about stem cells. So that's a great question. All right. Next question. What are your opinions on the classification of type 3 diabetes, linking insulin resistance and dysfunction to Alzheimer's disease?
Ooh.
I think the question refers to vascular dementia, so to vascular complications in the brain.
I think
I'm
so.
not sure.
I think we're still waiting for this. I don't think, from my understanding of the present, it's a formal diagnosis. I think it has been put out there on more media that this is a form of type 3 diabetes where there's glucose misregulation in the brain that potentially might link to the progression of terms of Alzheimer's. I'm not fully aware of all the research related to this, but as a formal term at the present time, I'm unsure we've actually introduced type 3 diabetes into our formulary in terms of that.
Right.
But I have heard it.
Okay.
So there are discussions definitely on social media related to this, but whether that's progressed into actually formal terminology with organisations, I'm unclear at the present time.
All right.
Unless anyone else knows. No.
All right. So let's see. Next question. Are there opportunities for students to take part in diabetes-related research at UCL?
There are opportunities for students to be involved in any kind of research.
Yes.
UCL is the place, right?
Yes, UCL is a place to do such a research. Yeah, we have some projects, including PhD projects or master students, and we will need to recruit participants, and UCL students definitely are welcome to join the research, and from like questionnaires, interviews, and sometimes you will be invited to use some products or devices, or go through some questions and provide your opinions, feedbacks to help us improve our design, our understanding of new technologies, or like the modern non-invasive like CGM technologies, something like that. So your opinions or your feedback are very important for us.
Right. Yeah.
I think we always look for students to help with our research. Every year we've got projects coming. We're always looking for students.
Yeah, come dissertation time.
Yeah, dissertation time every year.
Lots of opportunities.
Yeah. And if you're not the researcher, you can be a participant. Like Ken was saying. All right. So next question. How can we make methods of diagnosing young people with diabetes more widely accessible to all types of people, regardless of their financial state?
Good question.
With more funding.
Yes.
And Max.
I think this is an inherent issue that I think we're finding not just in type 1 diabetes. I think this is throughout healthcare. And there is massive health inequality that we see. Yeah. I think it's not just here. It's the fact that if you can afford to pay for healthcare, but if you can afford to pay for new technologies, new apps, you can pay for healthcare, you can get to see someone quicker, I think produces health inequalities. And I think the NHS do an amazing job. I'm a dietitian. I think we do a fantastic job. The challenge is always trying to be able to see as many patients as we can. And this is where we need to diversify and think about, okay, how do we use technology? How do we use digital? How do we move past what we've traditionally done in order to do that? But this is an inherent issue.
Right.
And it almost widens that gap where we see those who who are the most deprived in our country have the poorest health outcomes, whether that be for type 1 diabetes, whether type 2 diabetes. And I don't know the data related to engagement of people coming forward or being tested. I'm pretty sure we'll see it for everything. And that's a concern.
Yeah.
And I got asked recently about one thing that if I could do anything in the world, I would do. And I said, end world poverty. And ultimately, if we could, I think that would be a massive step towards making significant health advantages.
Yeah, it's hard. It's a very difficult topic to tackle. I mean, deprivation is something, but having the conversation, I mean, and keeping people engaged.
Because for many of us we're just ignoring that. This is an important risk factor. At least now we're a bit more honest and say, well, you know, this is a very important contributor.
I think early screening and education are very important as well. Actually, many technologies are not very expensive now. Like you can search online to get the necessary knowledge, can talk to many like chatbot, but don't believe them 100%. They're just like a source of knowledge. But you need to wear that. You need to pay more attention to yourself and your health condition. If you find something unusual, so pay more attention to it and get some exam and get some tests early, and that will be helpful.
Without taking time from the next question, I just want to add that this is something we need to do a bit better. The misinformation that comes from new tools, but also from social media that you mentioned earlier. This is something that we don't know how to do very well. My group is working, I have a PhD student that is finishing soon, working on ways to capture this misinformation. And I think this is an area that with the opportunities we have to access information now, people from very different backgrounds, without the filter that we have, they need to be aware of, and we need to be a bit more cautious of what kind of... we saw that a lot in misinformation in nutrition. So that's something we need to be aware of.
The amount of times I get asked something that starts with, I saw this on TikTok. I'm like, well...
we actually did some research the other year that asked people about how they engage, how they get their information. And it had healthcare professionals, it had social media, it had my friends and family. The biggest way people were getting health information, particularly around obesity, was social media.
Yeah, of course.
And then the lowest was actually down with healthcare professionals. And this therefore questions, okay, if it's social media, how do we as professionals, I think we need to really think about this, is how do we get us on, so how do we engage with the people? And we carry on doing the same things and over and over and over again. They're just going to come and speak to us. But actually, how can we get that out so that we can avoid that misinformation and make sure that we are there as well? And that's the challenge. And I think it would be good if we could do that better as a healthcare service, where we are stepping out of that initial comfort zone and actually going to the people on their own terms.
Right. And kind of linking that back to deprivation, most people do have a smartphone and or a phone that they use and watch, social media or things like that on. So that is an opportunity to, kind of, I don't want to use the word infiltrate, but to get, the foot in the door, to be able to be a presence that someone can kind of look to and get real information from for free. So, all right. So next question. This is going to be a good one. What is your view on Ozempic? Do any of your patients use it?
You're looking at me. Okay. So I think I've been in type 2 diabetes and obesity management for nearly 2 decades. And over the last probably 4 years, I've seen a step change in the management of both conditions. Ozempic is one of the medications. There's multiple others. They are GLP-1 or glucagon peptide 1 receptor agonists. So GLP-1 is naturally produced by our gut in the response to food. It helps with satiety, also delays gastric emptying, but also it helps with insulin production, but also it works centrally on our brain to make us feel full. And these medications have actually been around for a couple of decades.
Yeah.
They've been used. So we had exenatide many years ago. Byetta, we've had liraglutide, we've had lots of medications through the time, but the most recent, the step change, have been the more reintroductions of these new analogues that last a longer period of time. And that's been the really step change about how they have the GLP-1 in the blood for longer periods of time. And so now we've got single agonists, we've got dual agonists, we're now going to get triple agonists. Right. We've got on the stage, we've got oral, now we've got amylin as well. We saw some amazing data at Obesity Week last week as well. And I think they deal with biology. Now, if we think about diabetes, that has element. Insulin, for example, we're dealing with biology. So the GLP-1 is really helping when we're thinking about weight regulation. It helps to address that. It helps with insulin production. It delays gastric emptying. It also impacts on glucagon. So glucagon's released when our blood glucose goes low. But in type 2 diabetes, there's a misregulation with that. And what we have is glucose released from the liver, even though we don't want it to be released, and results in high blood glucose, and it deals with that. So these medications and the progression of future medications, I really think are going to be incredibly important for the management of diabetes. But also, interestingly enough, I think there's research that might go into type 1 diabetes as well, where there's insulin resistance. It's really exciting, but also other conditions. But what I really want to say right now is what we really need to do is we need to not forget nutrition, physical activity and behavior within this, and ensure that people have wraparound support. So there's a lot of people that are gaining access to these medications privately. And what we need to do is we need to make sure that people have access to dietetics, they have access to physical activity. We also have access to psychology as well. And because there's a risk with these, and that it might impact on your dietary quality, potentially vitamin and mineral deficiencies that we're starting to see in the literature, and excessive lean tissue or muscle loss, which might impact on functionality. I think we need to be mindful that this should be done in an MDT with healthcare professionals and not done by yourself through other means privately.
Definitely. Thank you. All right, let me take a look at these. I was wondering, since epigenetic mechanism seems to affect immune tolerance, do you think targeting them could complement immunotherapy approaches for type 1 diabetes in the future? That's Lucy.
Interesting. So epigenetics affects a lot of processes, and there are drugs that can target this. I mean, to say it affects immune tolerance, it's a little bit too broad brush, because there are many things that affect immune tolerance. And these things are regulated at multiple different levels. You know, it's not going to be all about epigenetics and regulating that. But I think what we are seeing in general is more of a holistic look at immune tolerance these days. I think we're starting to understand that a lot of different autoimmune conditions have a similar mechanistic basis, this loss of immune tolerance that happens very early on and allows the immune system to start getting interested in a bit of your own tissue. This seems to be quite similar across lots of different autoimmune diseases. So I think understanding more precisely the mechanisms of that, whether it's to do with epigenetics or whether it's to do with other processes, is going to really help us, not just in the field of type 1 diabetes, but actually across lots of different autoimmune conditions.
Oh, very interesting. Right. Let's see. So how could future policies be designed to support people in a way that reduces stigma and empowers individuals to engage with services for obesity and diabetes management?
I'll pass over to you.
That's a stigma. So
Yes, exactly. Stigma with.
So future policies. I say that we need to start a step earlier than that, before that, and policies are designed from people, and these people have to understand what is the evidence around the disease, the causes of disease, diabetes in our case, and what is the management path like. Bring the patient's voice into that policy design is definitely very important, and ask them what the needs are. I think that's something we should do in any scenario that we look at redesigning things for patients. We need to ask them what they need. And you mentioned earlier in questions about the work environment, the school environment, the university environment, the family environment. So the family support in a chronic disease is key. Policy brings it to the community, to the way we design, things like our cities or supermarkets or legislation. So I think we need to be in the cornerstone, because this is a very large discussion. The cornerstone, it has to be honesty and real interest to improve things.
So,
and that honesty has to come both ways from the patients. So keep that respecting communication to allow these to allow them to communicate these needs, and really want to do that. Not just say to do that. Before I pass to Adrian and Ken and Lucy, I think explaining to the people that are involved in policy design, which is our students, what is that evidence is important. And this is, I feel this is my role and our role in sharing the actual information, and not just sharing the evidence and managing our expectations on what can be done. Be frank about it.
I think you make an excellent point there. Our students are the future leaders.
Amazing.
Yeah.
And that is it. And if we can educate people, and this is what we've really tried incredibly hard within our courses, is to bring stigma in right at the start.
Yeah.
You'll see right at the start, it's in the first terms, we're talking about it, we're talking about language, and we're helping people understand about their biases, both their conscious but also their unconscious biases, and we get them to test it. But I think also, in addition to that, we need to think about how our societal view of diabetes basically is perceived. Where do we get this information from, and where do we get the ideas of obesity? And media plays a huge role in driving our beliefs around obesity, around diabetes, where they will say or suggest that type 2 diabetes is a lifestyle disease. They will put information or use images that aren't appropriate, whether that be for type 1 or type 2 diabetes or gestational. And these ideas, where the challenge is about how do we change the media narrative? How do we change that will help us potentially to change societal views? But also, when we're talking about policy, when we start thinking about the policy and how it's written, we need to be using person-first language. We also need to be moving away from having conditions put in behaviors when they're not behaviors, they're actually conditions, and changing the framing of which, because that's where healthcare professionals will get. They read it and they say, well, actually, this is a lifestyle disease, and the policy document I'm reading says that, or infers that, then where that will impact. So there's, it's so complex.
It's true.
But I think if we can make some small steps, I think that would be great. And Diabetes UK and the like have done some amazing work there.
Great. Well, do we have time for one more question for No? Okay. All right. Well, that's all we have time for today. We've reached the end of today's event, so we'll just need to wrap up here. A huge thank you to our panelists for sharing such fascinating insights into your fields. This discussion has been incredibly engaging, and with the rapid pace of technological advances, it's clear this is an exciting time for diabetes research. Before you go, we kindly request your feedback on today's event. A survey will be sent to you shortly after the event, and we would really greatly appreciate your input. Also, if today's event has inspired you to explore graduate studies in the field of diabetes, we warmly invite you to our in-person postgraduate opening evening on Wednesday, the 19th of November, where both myself and some of our speakers will be in attendance to answer any questions you may have in person. And you can find that link at the event page in the chat. Thank you so much.